Welcome back to Decode Healthcare with Harshal. I'm thrilled to have you here for part 40 of our 100-part ICD-10 CM guidelines series. Now, if you were with us for part 39, you know we tackled those tricky secondary and gestational diabetes overrides, but today we are shifting gears. We're diving into chapter 5 to conquer a very specific, very strict rule set, section IC5B, which covers psychoactive substance use, abuse, and dependence. By the end of this explainer, you're going to know exactly how to resolve conflicting substance documentation in a matter of seconds. Okay, let's dive into this. Picture this scenario. You're auditing a massive, complex medical chart, and you see the provider has documented a history of alcohol use, active alcohol abuse, and alcohol dependence, all for the exact same substance, all in the exact same record. For a lot of coders, this is an absolute nightmare scenario. I mean, what do you do? Do you code all three? Do you take a wild guess? Do you spend days querying the provider? Listen, if you assign multiple codes for the same substance on a single claim, you are walking right into a massive compliance trap, and it's going to lead to instant denials. So here is our roadmap for today's explainer to get you out of that trap. We're going to start with the substance coding trap, reveal the hierarchy golden rule, walk through some real chart scenarios, uncover the strict remission trap, discuss linking medical conditions, and then wrap it all up with your final compliance takeaways. Let's kick things off with Section 1, the substance coding trap, and how to navigate that overlapping provider documentation. So the crucial point is this. In the real world, providers just don't write in perfect ICD-10 CM code descriptions, right? A doctor might write notes over several days, or maybe multiple clinicians are all contributing to a single patient's record. And this naturally leads to overlapping, muddy terminology. One note says the patient uses cannabis, another says they abuse it. And if you aren't careful, your coder instinct is probably telling you to capture absolutely everything. But the CMS guidelines strictly forbid reporting multiple codes to identify the pattern of use for the exact same substance. You literally cannot report use, abuse, and dependence together on the same claim. The rule says only one code should be assigned. But how in the world do you choose the right one? That brings us right to Section 2, the hierarchy golden rule, or what I like to call the mandatory priority pyramid. To resolve this documentation chaos, the official guidelines give us a strict mathematical-like law that completely removes all the guesswork, period. Conceptually, think of a three-tier pyramid. Down at the very foundation, the base tier, we have use. This is your lowest clinical severity level. Right in the middle tier, we have abuse, which is a step up in severity. And at the absolute top, the apex, we have dependence. The golden rule is incredibly simple. The highest step documented in the medical record always wins. The highest tier completely absorbs the lower tiers into a single winning code box. Dependence swallows abuse, and abuse swallows use. And this brilliantly illustrates exactly how those combinations play out based strictly on section IC5.B. If you see both use and abuse documented, you code abuse. Abuse and dependence, code dependence. Use and dependence, code dependence. And if the chart throws everything at you, use, abuse, and dependence, you still just assign the single code for dependence. It's a clean sweep. The highest severity always overrides the others. So here is the ultimate formula you need to burn into your memory right now. Dependence is greater than abuse, and abuse is greater than use. This is an unyielding framework. It is the hierarchy law. Whenever you see overlapping terms for the exact same psychoactive substance, you just apply this formula and boom, you instantly find the single compliant code you need. Moving on to Section 3. Let's actually test this out with some real-world chart scenarios and resolutions. Let's look at example A. The doctor writes in the chart, patient has a history of alcohol use and active alcohol abuse. Okay, so we've got the terms use and abuse for the same substance, alcohol. According to our trusty pyramid, abuse sits right above use. Therefore, the active abuse immediately cancels out the history of use on your claim. You just drop the redundant lower tier term completely. Your perfect compliant resolution, code alcohol abuse only. That's F10.10. All right, let's try example B. The doctor documents cannabis abuse with cannabis dependence. Once again, two different diagnostic terms competing for the exact same substance. So, what do? We go straight back to the formula. Dependence is the apex of our pyramid. It is the absolute highest level of severity. Because dependence is documented, it completely swallows that abuse documentation whole. The resolution is simply to code cannabis dependence only, which gives us F12.20. It really is that straightforward. Now let's shift gears and look at Section 4, the strict remission trap. This is where a lot of coders get caught assuming things they shouldn't. Now, what's really interesting about this rule is how it strictly limits us as coders. Very often, a patient will tell their doc, hey, I haven't touched a drop of alcohol in 10 years, or I've been clean from opioids for a decade. And as a coder reading that, you might be super tempted to just assign an in-remission code based on that awesome timeline. Do not do it. Doing so is a massive compliance violation. The CMS guidelines are explicitly clear. Selecting an in-remission code requires the provider's clinical judgment. Coders are strictly forbidden from assuming remission based on sobriety timelines, negative lab results, or just personal assumptions. If the provider doesn't write the actual word, you have to query them, or you risk an auditor slapping a huge rejected stamp right on your claim. But hey, when the provider does properly document it, the guidelines tell us exactly how to map that clinical severity. If they note a mild substance use disorder in early or sustained remission, you classify that to the appropriate code for substance abuse in remission. If it's a moderate or severe substance use disorder in remission, you classify it as substance dependence in remission. But remember, the absolutely critical takeaway here, the absolute deal breaker, is that both of these scenarios require the explicit word remission from the provider's pen. Let's move to Section 5 and see how this builds when we bring physical diagnosis into the mix, linking medical conditions due to substance use. You know, very often, prolonged substance use or dependence causes severe physical damage to the body. But here's the catch. Medical conditions are not classified as substance-induced disorders on their own within the mental health chapter. You must assign the medical condition code alongside the appropriate psychoactive substance code. So, for example, if the documented condition is alcoholic pancreatitis due to alcohol dependence, you don't just hunt for a single combination code. You have to assign the diagnosis code for the medical condition, which is K85.2 for alcoholic-induced acute pancreatitis, and you sequence it with the appropriate substance code, which here is F10.20 for alcohol dependence uncomplicated. You always report both to capture that full clinical picture. All right, we made it to Section 6, Final Compliance Takeaways, to ensure you are submitting flawless, audit-proof claims. We have covered a ton of ground today on Section IC5B. To ensure you walk away fully empowered, let's distill this down to the absolute most critical rules. First up, never, ever code use, abuse, and dependence for the exact same substance together. Second, rely on the golden rule. Dependence trumps abuse, and abuse trumps use. Third, in-remission codes cannot be assumed. No matter what the lab results or timelines say, they require the explicit word remission from the provider. And finally, when a physical medical condition is caused by a substance, link them up. Code both the medical condition and the appropriate substance code. So I've got to ask you, next time you're staring at a chart with overlapping substance documentation, are you going to fall for the trap? Or will you let the hierarchy rule guide you to absolute accuracy? Mastering these strict CMS guidelines is exactly how you ensure your coding is fiercely accurate and completely compliant. That wraps up Part 40 of this Explainer series. Please make sure you hit that subscribe button, leave a like, and drop any coding questions you have down in the comments. I'll see you right back here for Part 41, where we move into Chapter 6 to conquer the dominant versus non-dominant side rules for hemiplegia. You definitely don't want to miss that one.